Okay, we're going to go ahead and get started. We are excited that we have such a great turnout on a day that's icy and short notice. So I think it speaks to the importance of the topic and the giftedness or blessedness of being able to have a speaker come and be willing to kind of add this on to his trip here to Denver and be able to share with us. And I want to thank Dr. Carol Runyon for making the connection such that we can take advantage of the opportunity. So for those who may not know me, I'm Ailene McCarran. I'm in the Department of Health Systems Management Policy, and I'm serving as our interim dean for the Colorado School of Public Health. And I've also served as the Associate Dean for Practice, and I thought this would be a great opportunity to kick off what I might imagine will be a series of these kinds of forums, our Public Health Practice Spotlight Forums, where we are able to bring in outside speakers and thoughts so that we can have convening conversations around topics that are happening in real time. There's going to be another speaker joining us in April 6th, I believe, during Public Health Week, and it's the Director of Policy Evaluation for the American Schools and Programs in Public Health. So again, these are opportunities to spotlight in a rapidly moving environment and have dialogue. So thank you for joining us. So I'm proud to introduce Larry Cohen, who is here with us today, and I'll give a bit of the bio. Larry's a social worker by training, and he's the founder and executive director of the Prevention Institute. And he's really been an advocate for public health, social justice, and prevention for the last 40-plus years. He was one of our spotlight speakers in our Center for Public Health Practice in one of their symposiums a couple of years ago when it was focused on mental health. And so we're delighted to be able to welcome him back again. He established the Prevention Institute almost now 20 years ago, 1997, as a national nonprofit center dedicated to improving community health and well-being by building momentum for effective primary care. And the Institute's work is characterized by a systems approach to prevention, a strong emphasis on community participation, and promotion of equitable health outcomes among all social and economic groups. He has an ear to the national happenings, and I think we'll be able to share some of that perspective with us, and we hope that there's good dialogue. I unfortunately had a conflict for this time, so need to step out, so I'm going to be turning the mic over to Dr. Carol Runyon, who will be serving the mic for the Q&A portion. Wanted to let you know that this is being taped, so that those that are not here might have the opportunity, but it might also be, just so you're all aware as well, it is being taped. And without much ado, I will turn it over to Larry. So thank you. I even wrote a note saying, Elaine, don't forget to announce. So one of the things that we're trying to do is to make sure that the voices of public health, our students, our professionals, our faculty, how we take our stories so that they can have an effect. The Government Relations Forum for the campus, for the university, is our representative in Washington, D.C., representing our interests as well. And so they are looking for stories, student experience, personal testimonials around the effect of the Affordable Care Act. So if you are interested in the support of the Affordable Care Act and have been benefited by it or have a personal story, we ask that you send that to Cerise Hunt or touch base with her after.
Sign up.
Yeah.
So if you want to sign up and put your name and follow up.
Or if you know that there's other associations and groups within your networks that have pulled together stories like this, we're trying to curate this and share them with our government relations so that they might be stories that can be shared with our own local legislators to make it Colorado relevant. So wanted to make sure that announcement is in. So now, without much ado.
Hi, everyone.
You're Mike.
I'm Mike. Yeah. Good afternoon. You have to respond because this is a conversation. And I'm less facile and less prepared than in almost any other conversation I've had like this because we're really learning as we're going. I'm speaking more from notes because there are several people who've shared some information with me that I want to share broadly. And I hope this will prove helpful as we really think about where to go. I want to tell you a little bit about myself, and I want to talk a little bit about what we know right now in terms of the national situation, the implications for prevention and for health and for health care, and also some thoughts about what to do. And I want it to become a dialogue, or whatever the word is for a 60-a-log. As we kind of, see other people may know a lot of other pieces, or more relevant Colorado elements or something like that. But since it was mentioned that the last time I was here was to talk about mental health strategy, I'll say that this election is perhaps has the largest mental health consequences of any I've seen, in terms of excitement on some ends, trauma on some ends, nervousness, people not sleeping, all kinds of stuff. I'm coming here, living near where there was a demonstration last night in Berkeley, and some very legitimate demonstrating, and some deliberate destruction from a small group of people. And having seen some of that before, really, really pleased actually that it was handled so well with no injuries and no arrests, which, is promising. My niece told me that she doesn't know how to dress her kids in the morning anymore, because she no longer listens to the news and the weather. And I think it's been a really interesting phenomenon, because I know there are a lot of people who are saying, I really need to know what's going on. I don't want to know what's going on. And clearly I'm coming from the place of I need to know what's going on, and I don't want to know what's going on. My career is something like 40 years in prevention. I'm not sure exactly, and I don't like to count it. But it started out when I was working in mental health, and I had this problem. I don't know whether anyone here has had it, but I was working in community mental health, and the work was going really well, but I decided that the influence and the impact was going to come from government. So I went to work in a nearby county, Contra, Costa County. Has anyone ever had a boss you didn't like? I know a few people can't raise their hands right now. But I decided I had to get out of mental health. And at that time, the county had become the first county in the United States that, as a county health department, kind of had its own kind of HMO. And the federal government approached it and said, hey, we've got a deal for you because we're worried about rising costs. And the deal was that the county would take 90% of the money it had gotten the year before. And so that's great for the federal government. And in exchange, would not need to do the billing. And so that was great for the county, because the county said, billing probably costs us more than 10%, plus everybody hates doing it. So, so it seemed like this really good thing where they get paid in effect by patient rather than by illness. And so as they discussed this and the pros and cons of it and decided to go after it as a national model, they thought it would be fun, somebody suddenly said, well, wait a minute, then we can emphasize prevention. We can do something about prevention. And as they started talking about prevention, the one example that came to mind was someone in the town 30 miles away, which is called Pittsburgh because it has a steel mill, and it's like Pittsburgh, Pennsylvania, who would have an asthma attack, perhaps once a month, be brought to the hospital, usually by ambulance, 30 miles, and everybody would kind of laugh, frustrated, and say it would be a lot cheaper to get him an air purifier and an air conditioner than it would be to keep driving him back and forth, but that's not billable. So all of a sudden they said, well, that's billable. We don't need to bill, so we can do that. And that was the only example they had of prevention. And I was working in mental health treatment. I thought prevention had nothing to do with equity. But I decided they only would hire somebody internally. They created this prevention position. They'd only hire somebody internally because they didn't really think it would work. So they didn't want to create a new position. And I decided to apply because I hated my boss. And it was either that or I was going to go to Mexico and study Spanish, which might have been a better decision. And that became the beginnings of my work with prevention. And I'm saying this because here we are, 30 or 40 or whatever number of years later is, I think it's 36, at a time where we really know what to do about prevention in a way that we really didn't then. Whether we're talking about prevention of violence, where we can cut the rates in cities, where we can reduce family violence, whether we're talking about, things like car seats, where initially we were working with hospitals because as the first car seat laws came into play, parents would still take their young babies from the hospital without thinking about having them in a car seat when they were going home. Establishing a lot of the elements, a lot of the principles of prevention. I did the country's first no smoking laws. And it became clear that it wasn't just telling people not to smoke, it wasn't just smoking cessation, but what prevention is about community-wide environmental norms change. And it's about multifaceted approaches. So we understand all that. We started, particularly maybe on a national level, mostly, though before that, but particularly in the Obama administration, which actually wrote prevention into the Affordable Care Act with a national understanding and commitment of prevention. And I remember, and I worked on that a lot with lots of other people. But we'd established Prevention Institute. It's based in Oakland. We established Prevention Institute because there wasn't a focal point to really think about prevention as a discipline across topics. What are the skills? What are the methods? What can we learn from one issue and apply it to others? And so there we were trying to promote prevention, and all of a sudden I think the Affordable Care Act was $13.2 billion. And it's like I turned to our staff, I said, I can retire and we can close Prevention Institute. Our work is done. And very clearly, not only for political or funding reasons, but for lots of reasons around how do we really develop quality prevention in this country, the work was not done. But what I loved about the Affordable Care Act was that prevention was the first piece funded. That was a very clear statement, and that was a fatal flaw. Because it moved, if you didn't like the Affordable Care Act, or if you didn't want to associate yourself with health because health always has problems and so it's better to blame it on someone else, or if you didn't like Obama, you would be opposed to ACA, and so the first thing you'd want to get rid of is the first thing that emerged. So prevention has been on the chopping block. And I can't remember the number, but I think there were 150 different, give or take, 150 different legislative proposals to eliminate the prevention funding over the last 8 years. The question now is what's going to happen. And I think that unquestionably, prevention is bipartisan. Nobody likes getting sick or injured. And everybody likes a system that reduces the likelihood of getting sick or injured. And we've been doing some work on what we're calling social return on investment, showing a variety of ways, both financially and above and beyond financially, that prevention makes sense. So obviously that's preferable. It's preferable to save money, it's preferable to save lives, it's preferable to reduce misery. That's bipartisan. But the question is, if on the other hand, this notion of community prevention has been picked up and has become somehow partisan, then we lose it. So that's where we are. Added to that dislike and all the issues in the current administration about repeal, is the financing and the notion that there's going to be a lot of cuts. And so that's in a way the context. So I want to lay out this context. I wanted to, kind of do that, and to keep in mind that prevention may be most successful, but is hardest to understand when it's integrated and braided and multifaceted. So you can talk about heart disease prevention, and you can talk about cancer prevention, and you can talk about diabetes prevention, and each of those feel very tangible. Somehow mixing them together doesn't, though if you look at what underlies heart disease, cancer, you're going to see what are people eating, how physically active. There are a lot of commonalities which are best addressed in a unified way, and most effectively and cost effectively addressed in a unified way. But very clearly, the directions in which we seem to be headed are really, really different from that. And I think one thing, looking back and looking at the Dean's question about stories, is we have done a very, very bad job as a community or as a nation over the last 8 years of really promoting effective prevention. I'd say probably there's been a complacency in the public health community, and that complacency has meant we just accept it's going to be there, it doesn't matter. So these stories have not been told. And I've talked to people who are big prevention supporters in Congress who basically say, I'm not hearing from my communities that this matters. And so now we need to move from complacency to voice. And when I say voice, I'm talking about prevention. I also want to mention, though, in addition to prevention, there are several very, very important pieces of the healthcare system that really align with prevention. And the first, going back to the story I told about saving the money, the first is that there's been increased emphasis over the last decade or so on payment mechanisms and on moving payment nationally. Sometimes it's called pay for quality, sometimes it's got a lot of different names, but the gist of it is it's crazy to pay for more medical procedures rather than to pay for the best medical procedures. And furthermore, if we can reduce the intensity and severity of what's needed, that makes a lot more sense. So how do we start to recalibrate, redesign our medical system? And of course, people do what they're paid to do, and people go where the incentives are. So how do we switch those incentives? So that's a very important thing that's been happening along with prevention over the last administration. Another piece, and separate from, when I say the administration, it's been happening separately as well. It's been happening from healthcare institutions. It's been happening from community institutions. It's not just a Washington, D.C. thing. Separate from prevention and the funding, there's a couple of other things I want to mention. There was out of the Affordable Care Act, there was the beginning of a group called the Center for Medicaid and Medicare Innovation, which is part of CMS. And the Center for Medicare and Medicaid Innovation, basically their goal was to look at innovative strategies that would save money or that would improve quality for the same money. And if those strategies made sense when they were tested, to implement them across the nation and to use the force of Medicaid, Medicare, in California, Medi-Cal, other CMS functions for children, AMCHIP, to start to have that kind of impact. So you have CMS or CMMI, you have the Prevention Fund and other prevention issues, particularly integrated, comprehensive prevention. You have the payment mechanisms. And the other thing that's been really important, I think, has been the support, which is also supposedly bipartisan, of community clinics. Community clinics are very important because community clinics was a movement and an initiative set up to be more community-oriented, to be more advocacy-oriented, to be more health rather than simply healthcare-oriented. So those are 4 building blocks I want us to point to where we don't know what's going to happen. And I'm sorry to come here as a speaker without information. But we don't know what's going to happen. But we do know that there's potential interest and potential in all 4. Community clinics have been seen as a very strong Republican and Democratic agenda item for somewhat different reasons, probably. But community clinics have been seen as important because they serve rural communities, because they serve a variety of populations that otherwise don't as easily get care. I think there's also a hidden agenda, which is if you create more community clinics and say, hey, we're funding them and they're the providers of last resort, then you don't have to kind of put as much money in the health insurance system. You don't need to guarantee everyone coverage because you can say, oh, the community clinic is the coverage. So I think that's a piece of what's been going on in Washington. The other word I want to raise kind of as laying out these building blocks is equity, because the word equity or the word disparities has been a central divisive element. With equity for who? Are we talking about race? Are we talking about low-income white populations? Are we talking about women not being paid what men are paid? So we know we have an inequitable health system, and we know we have health disparities, and we know we have a system which creates health inequities, and yet there's an antipathy to that framing in the current administration. So those are the kind of the building blocks, I think, that we need to pay attention to as we're watching now and seeing what goes, because in each of those areas, there's some potential opportunities. You know, in one of the quotes, when I was reading through some quotes, because I was trying to find some inspirational quotes at this time, and one of the quotes was, there are always opportunities. They're just in different ways, and you just kind of have to dig them up. So these are 5 areas that I think are worth watching, you know, for opportunity. Even within the last Democratic administration, when Senator Harkin resigned, he was the loudest voice for prevention. He was the loudest supporter of prevention from CDC. So one scenario is we lose, there's significant cuts in health. The Affordable Care Act is eliminated very, very quickly, and the prevention fund goes with it. The prevention fund over the years has been diluted and modified. The $13 billion pieces have been taken, including by the last presidential administration. But right now, the funding associated with the fund is 12% of the CDC budget. And if you think about the need for a functional CDC and say we're going to cut 12% out, that's a major concern to the nation. And I think it's a major concern to the people who are now running the health system in the country. Another element that people from CDC have mentioned to me, and it's maybe just hopeful and not necessarily well-grounded, is that Dr. Price, the new head of Health and Human Services, is from Georgia, was a representative from Georgia. And if you start cutting CDC, you start increasing unemployment in Georgia, so that's not such a popular thing to do either. And in fact, all the cuts being talked about in government and all the cuts being talked about in health funding have an impact, obviously, on employment. And with employment figures increasing every month in the last administration, you know, there's some levers we can mention, we can talk about. So although it's really good that people are collecting stories and trying to collect stories, in addition to the stories, it's important to collect jobs and to talk about the job impact, and it's important to talk about financial impact. Direct funding over the last few years from the Prevention Fund into Colorado was $25 million. And I have the figures of exactly where that went. A big chunk of it went to the Denver Health Department for a community transformation grant. Some of it went to the state. Some of it went to some hospitals for a variety of different initiatives. But these are, a number of the things that I think you want to pay attention to. And I was, people said they're sorry it's cold here, but I was in Anchorage 2 weeks ago, and I met with the health director there, and he had just met with Senator Murkowski, who's a Republican senator, in a more, I don't know kind of how to describe the politics of Alaska, but in some ways they're kind of similar to Colorado, I think. There's kind of a bipartisan sense of direction, a certain libertarian element. But when she heard about just the work they were doing and the opioid issues they were facing, and working with him closely on that, and he said, well, just from the Prevention Fund, that's 7 jobs out of my department right now, that really alarmed her. When he started to give her the figures about the money that would be lost across the state from community transformation grants, which have now new names, Peach, from Pitch, Reach, and others, she started to get very alarmed. And she basically said, well, my voice is going to be that doesn't happen. So that's the kind of local work that needs to be done. That's the kind of message. It's the stories, it's the money, it's the jobs. There may be other things, and we're going to open it up for discussion. There may be other things that can be added to that. My colleague Sana Chahimi, who's based in Washington, was part of a group of 3 or 4 people that have gone around this past week and have met with a lot of Republican Senate and House members and aides to try and get a sense of what's not being said and to try and get a sense of what's actually going to happen. And one of the optimistic things about the Prevention Fund is almost none of them feel like this 12% cut to CDC, if it were to happen, could happen quickly. And that we're certainly talking about several years. So all these things about ACA would be eliminated the first day, and my thinking, well, the first and easiest thing to get rid of is the Prevention Fund. There's a lot of fear and a lot of concern and a lot of recognition about that. So that's good news. It's news we need to build on. On the other hand, when I described effective prevention earlier on and talked about comprehensive and talked about multifaceted, and talked about, I'm not quite sure I said this, but that it's about the community environment, that's not where the sympathy or the understanding sits. The image of CDC and save the money and protect CDC is probably about the next Zika virus, though perhaps a Zika virus not just for hot climes, though the hot climates tend to be more of where the red states sit and where some of the more powerful people sit. So there's a lot of fear about the viruses, and we can't debilitate CDC. But that's one of the pieces of good news, is the money may be there, but as I said, it doesn't make sense to have separate funding for heart disease, for diabetes, for cancer, for the same solutions, but that's no question. That's where we've been headed over the last few years, and that's where we're going to be headed even more so. What that means, if we combine that with another term we want to use, local control, what that means is there's an opportunity to say, okay, we've got this and this and this, and some of those resources coming to us here locally across Colorado. We need to, a word I like a lot, we need to braid those resources so that we start to have the most effective, comprehensive approaches. I mean, one of the things that I think is an opportunity is the notion, if prevention is accepted, it's not accepted that on a national level, people are telling people in states and localities what to do. That's one of the clear shifts and transformations. So if that's one of the clear shifts and transformations, then one of the opportunities is to say on a local level, we can and should get prevention. And places like this university need to be the spokespeople for what effective prevention is for the state and how important it is to do so. And I've met a number of people within the state government and within the Denver government and a couple of other places, and I've worked with a number of nonprofits, and you've got a really strong, sophisticated group of people here. But it's a question of really a refined, strong, coordinated prevention message. And it may be a sense of new partnerships and a new collaboration to do that here in the state. That hasn't happened. So public health and prevention funding, particularly at the federal level, is going to be more narrow, disease-specific. And it'll continue, meaning it's up to states to make it comprehensive. There'll probably also be a big shift from mandatory funding. Now, this is all, I just want to emphasize, everything I'm saying is tea leaves. This is talking to a number of people and putting together what they're saying now. And so we're assuming the people who did the talking were strategic and right and smart. And we're also assuming the people who told them the things meant what they said. But even more so, we're assuming they may mean the same thing in a month. And we know things are moving really rapidly. And we can't necessarily count on that. But there'll probably be a shift from mandatory funding for prevention and public health to funding coming down much more in a block grant where states decide where the resources go. This is always a big danger. This is a state where perhaps there can be some maneuvering around the danger, but this is a big danger because the medical institutions are more powerful. And the medical institutions have not yet bought in nearly enough to the strategies on prevention. I did want to say that some of our work, that for years we never worked with healthcare very much because we're really trying to focus on in the first place and didn't want to get distracted. But about 6 years ago, I think it is now, we launched an initiative called Community-Centered Health or Community-Centered Health Homes, where we said for that when healthcare recognizes that 90% of the determinants of health are outside of the healthcare system, maybe they'll start to recognize that they need effective strategies. And when they recognize they need effective strategies for community-oriented prevention, they need to understand that although they're very smart on medicine, there are people who figured this out in public health over the last generation. They need to partner with them, they need to learn with them, they need to engage with them, and so forth. And that's the initiative we're involved in. I'm very worried about its continuation and success, but I'm hoping, because of the tea leaf part, about the support of community clinics. That's one of the places where it can flourish and is being experimented with a lot. The best hope for comprehensive prevention might be, there was just recently the 21st Century Cures Act, which actually took money out of the prevention fund and put it into, this was in the end of the last administration, but, like in the last week and in a way, was a hostage taking of money from the prevention fund. But the Cure Act put money into things including the cancer moonshot, funding for NIH. So how do we replicate some kind of a 21st Century Prevention Act? And how do we do it, and what is the language, and what is the wording that has traction with the current administration? But that's perhaps, there's some feeling people will be open to that. So right now, we need to communicate the importance of comprehensive upstream prevention, the importance of public health investments overall. We need to communicate the impacts of the prevention fund on the ground, both the impact on people's lives, the impact on health, the impact of jobs, the impact of resources. And therefore, that we need to develop a replacement mechanism. That somehow, on a national level, we need to develop a replacement mechanism that has impact. So your work or our work or all of your work is both on a national level, in part through statewide partners and in part through any affiliations you may have. And it's also on a statewide level to say, how do we organize effectively to do the work? I'll tell you frankly, I was surprised by the courage of our governor, who gave a talk a week ago, Jerry Brown, and said, nobody's going to lose health care no matter what happens on a national level. And that did not happen just from his courage. That happened from a lot of people organizing and working on it. And that kind of behind-the-scenes work is really, really important here. A couple of other things in terms of facts that I want to talk a little bit, focus just for a minute, just on what we need to do. Although there's continued lack of agreement among Republicans about how to replace the ACA, there's a feeling that repeal eventually is a certainty. And that the challenge is that at that point, if it's not better, and it's very hard to make it better and to save money, it's impossible. You know, if at that point it's not better, it becomes then something Republicans own. And I'm sure a lot of you heard about the taped secret conversations where legislative reps were talking with the administration and said, you know, we got an election coming up again in a year and a half, and if we're going to make health care worse for people, you know, they're going to hold us responsible for it. They're no longer going to blame the last administration. So that's good. Right now, there was an executive order which required easing the burdens of the ACA, and the Secretary of HHS will have discretion to stop enforcement of those provisions, you know, unless they're repealed through reconciliation. So although there's an executive order, in a way that may be mostly a PR order, because it's not clear how or whether it's going to be used. So the advocacy actions related to the ACA have basically been, don't repeal. If it's repealed, it can't be repealed without a viable, comparable replacement. And most importantly, from my perspective, in fitting into this, don't repeal the prevention fund. Let's delay the repeal till we identify a replacement strategy and build on the notion that everyone on a bipartisan, irrespective of politics, everybody knows prevention makes sense. So we're not going to walk away from prevention. We can change the tenor. We can change the nature of it. You know, one more thing about Tom Price is that there's very little indication of what he thinks or believes about prevention. And I don't know if people watched the hearing, but he was asked what the largest preventable medical condition was. And his answer was, well, it looks like you had that on a piece of paper, so why don't you tell me? And the response was, okay, it's tobacco. Can you tell me why you've held tobacco stocks for the last 10 or 15 years? If you're, as a healthcare provider, were you aware of that? And he said, well, I didn't know what stocks I had. You know. But that was the only response we got in terms of prevention. So we don't know what we're going to get, what we're going to see. You know, the only sign of hope from someone who's much more hyper-medical oriented and interested in new innovation means new technology. The only sign of hope is the fact that he's from Georgia. So there'll be CDC people and other Georgia people, you know, who have contact with him. So 3 words: tenacity, audacity, flexibility. Tenacity means we got to keep fighting. We got to keep demanding. We got to keep insisting on holding on to what we got. Audacity means we're going to move forward despite the setbacks on a national level. And the we might mean the state, it might mean the school, it might mean some of the cities, the counties, but we're going to move forward. You know, I don't have the patience to, to just wait. I have too many ideas to just kind of say, I need to go back just to defending things that were obvious. I just had an article was published of ours in U.S. News and World Report about immunization and the notion that there's going to be a whole study of whether immunization causes autism, based on an article that was written 15 years ago, which then even the author admitted was fraudulent and that the journal issued an apology for. But we don't have time for that. We got to get on to the real work. We got to get on to, we're talking about real people's lives, and that's the stories we have to tell. We're talking about real people's lives. We're talking about stuff that really, really matters. And flexibility. We're going to have to find out new ways to do it, new ways to talk about it. On the issue of equity, for example, I think the emphasis on people of color and disenfranchisement and structural issues was exactly right. And I think we really failed at the same time to pay attention to inequities that were facing others as though they didn't matter. I remember a while ago noticing that the only people you could make fun of at some point on TV comedies were white men. And there's a backlash, but there's also an unfairness for low-income, struggling white men who somehow they don't matter as much because they're white. And I think we have to redefine our equity issues in a way that's more inclusive and also includes geography. We're talking about rural. And not to say, because I'm talking about white men, that there aren't more inequities facing women than men, and we have to pay attention to that as well. But we just need to be more thoughtful, and the other word I would use, I think, is compassionate about how we think about those issues. Some prevention is still going to be possible at a national level, but we need to figure out from the flexibility standpoint. Keep in mind, one of the innovations in the prevention strategies of the last 8 years was the National Prevention Strategy. And the National Prevention Strategy brought together 15 different departments and agencies. Transportation has a tremendous impact on health, economic development, parks. We all know the issues. We all know the groups. There will be opportunities in some of those places. We need to seize the opportunities in some of those places. And equally, we need to speak up from a health perspective about the damages. The EPA is not just a group that's concerned about the environment. The EPA is a group that's going to affect asthma rates. The EPA is a group that's going to affect cancer rates. We need to speak up about that. We need to make those kinds of links. But when we share prevention successes, we have to not only talk about local impact and outcome, we need to talk about co-benefits for healthcare, for schools, for local government, for business. We need to make sure this is big picture stuff. Prevention is about our kids learning. Cutting prevention is damaging our kids' ability to learn. Prevention is about productivity. When a woman is beaten by her husband, it has enormous effects within the family, but the entire workplace stops. It's not just she doesn't show up. She does show up. And how is everyone spending their time? We need to be telling those stories. We need to be, the biggest mistake I think we've made in prevention with business is we've equated business with the certain specific businesses which are the problem businesses. So we say, oh, business, we're anti-business because I'm anti-tobacco. I did the smoking laws. R.J. Reynolds tried to bribe me and threaten me and It's a story for a different day. You know, but instead I should be saying, wait a minute, businesses really care and need to care about tobacco prevention because that's going to save lives, reduce healthcare costs, improve productivity. That's the business story we often fail to tell. And this is a critical time right now to tell that kind of story. I want to note that some of the best prevention work I've done has been within Republican administrations. And some of the best prevention successes we've seen have been within Republican administrations. I do think things are different, however, which worries me, partly for fiscal reasons and partly because of this whole notion of change everything, disrupt everything. But I do think that there's a chance of that reminder is both important for us and is also important as a tool to remind our legislative leaders, our decision makers, of this notion that good prevention is bipartisan. Yeah. I think I'll just stop and say we can't get caught up just in the politics that prevention is about people's lives. It's about health. Obviously, I'm speaking of this from a perspective which is not fully bipartisan. I'm frustrated, I'm angry, I'm disappointed. But I think that can only be part of the story. I think we have to speak to everyone. We have to speak as everyone. And we just can't allow misery. We just can't allow misery. So I'm going to stop there. I've tried to do this. I hope it was helpful. I mean, I'm really just kind of grabbing bits and pieces, but it was helpful for me to figure it out, so I hope it's helpful to others to kind of think about it. And I want to open up for not only questions, but additions and also comments. So
I've got the mic. Thank you for that. Your thoughts, ideas, concerns?
So that was
and tell me who you are. If you would.
Yeah, hi, I'm John Douglas. I'm the director of something called Tri-County Health Department, which is a metro area local health department. Can you speculate a little bit about the interest of hospitals? Well, first of all, can you clarify what you think is going to happen with the whole community benefit plan effort? So the IRS reg still exists for nonprofit hospitals. What's their incentives going to be to look at community prevention? And what are the incentives within MACRA that we ought to be aware of? And you know, the Medicaid and CHIP Reauthorization Act, which is pushing value-based
Yes.
Payment.
Yeah.
So that's apparently a bipartisanly agreed upon act.
Hopefully, yes.
And so as we reframe our thinking and look for new opportunities, do you have any reflections about that? Hospitals and MACRA.
Yeah. I think that as far as I know, that the community benefits perspectives will remain. And for people who don't know what this means, it means that hospitals get tax benefits, such as not paying property tax if they're a nonprofit hospital. And that part of the trade-off is that some of their resources go for what are called community benefits. And sometimes this is used well by hospitals, sometimes it's not. And there's some requirements, and just the past couple of years, the IRS, because this is a tax requirement, the IRS held a set of forums and hearings to basically reshape the community benefit regulations in some positive ways and some not so positive ways, I think. But generally speaking, the assumption is that most hospitals will continue the community benefit requirements. In some subtle ways are different, but more or less are the same. It's sometimes harder to do community prevention because they're looking more for actual outcome, which they define more as medical, and it's harder to show or measure some of the community prevention. Hospitals are required to do community plans. But my sense, as far as I know, is that's going to stay roughly as is. I think there's a really important challenge, which is getting hospitals on board with prevention not just through community benefits, but to make it a more fundamental part of their understanding of what the work of their institutions is and needs to be. And that's where our community-centered health homes work comes. There's about 5 different philanthropically supported collaboratives across the country looking at this in different ways. And there's been an initiative recently called Anchor Institutions. And what anchor institutions are, and this is something I think we'll want to build on over the next few years, what anchor institutions are is healthcare and sometimes other groups and universities recognizing that they are key institutions within a community and that they can and should take more responsibility for the community's well-being. So this particular university owns a lot of property, hires a lot of people, buys a lot of things, buys a lot of materials, decides what to name the building. I mean, this is a spectacular building. What's the quality of the food that's available? Does the public health building, when I go for coffee, really need to have donuts as kind of the only snack? Or maybe it's just because I got there late. But this notion of anchor institution, where hospitals are starting to understand they have a role in terms of their institutional nature, is starting to catch on. And there was just a major meeting in Washington of about 70 different anchor institutions, including Catholic Health Initiatives is a major sponsor of that, and they have healthcare right here. And one of the leading people who I just met with over lunch actually went to public health school here, as well as to medical school here. So, so there's potential with stuff like that. Okay, great. I didn't answer macro. We'll talk later. Thank you. Yeah.
As you've been, I'm Jimmy Corrado. I'm in the School of Public Health and the Leadership in Public Health Practice program. As you've had these conversations around the country with the ACA repeal being kind of a foregone conclusion, do you realistically see anything happening that's going to impact what the ACA provides prior to the 2018 election? I mean, there's so many political considerations in here with them wanting the majority party wanting to be a larger majority. Do we really think there's going to be these things that are, like hitting a brick wall before that period of time?
There are mixed indications of that. That's a very astute question. And I've been definitively told yes and no by different people. There are people who say, we're just going to wait for exactly the reasons you say, and there are other people who say, we're going to move right now significantly. There's been a lot of trying to do both, which is to say, let's repeal and replace, but not have stuff go into effect for a while. And my guess is there'll be a fair amount of that. But I think the other thing there will be is less change than was initially planned for. Because there's too many things. Because it's hard to change one piece without changing another piece. And some of the pieces are very popular. An example, many of you know this, is Kentucky, where the polls were taken, and I think it was 80% of the people hate Obamacare, and 60% of the people love Kentucky One, which is their healthcare system, which is the Obamacare. So if you get rid of the Obamacare, unfortunately, they've just realized they're going to lose Kentucky One. And they don't want to lose. It was like the person who was walking around saying, government, hands off my Medicare. Keep your hands off my Medicare. So those are the contradictions. So I believe there'll be less change, but frankly, what I'm hearing is a mix, and just as many people say, it's going to happen sooner than we think.
Hi, my name is Sarah Miller. I'm with one of Colorado's public health institutes. We've met in the past.
I know, it's nice to see you.
It's good to see you too. And thank you for the work you've done over the years. I've stood on the shoulder of your giant work, so thank you for that. Can I dig a little into this, your thinking and any inspiration about coordinated prevention messages? Are you seeing any samples or not samples, but examples of things starting to percolate that we might be able to learn about here in Colorado?
I work with a group called Convergence Partnership, which is some of the major health and other health-related philanthropies. It includes Kresge Foundation, Robert Wood Johnson Foundation, Kellogg Foundation, California Endowment, MacArthur Foundation, Kaiser Permanente, Nemours Medical System, Ascension Health System. And we're the staffing for that along with PolicyLink, are releasing a statement tomorrow morning, which basically is in strong support of prevention and equity, and saying that prevention work must move forward. It's not the one to copy, frankly, because it's very careful and cautious. It's basically making a statement about the value of prevention without talking about some of the specifics that ideally would be said, but there's a lot of different politics in different places. And I actually said, let's just get something out as opposed to spending months trying to wordsmith it. But that's, I think, a tool, a very important tool. These are the main spokespeople for health from the philanthropic level in the country. They provide a lot of the pilots. That'll be on our website tomorrow. We're going to have an alert about it. If people are not on our mailing list, please give me your email or take my card and get on our mailing list if it's of interest to you. And then I think, we're going to hold a web forum that I'm speaking at, which will be more organized and more knowledgeable than I am right now, I think it's February 28th, in partnership with Trust for America's Health, which does a lot of the advocacy from the inside the Beltway perspective. Yeah, it's February 28th, and information will soon be out and on our website. In partnership with Trust for America's Health, Prevention, Public Health Institute, and the American Public Health Association. Our four groups are coming together to do this webinar. They actually held a webinar sharing some of the information I shared with you a couple of weeks ago, except we didn't have as much information then. But this will be, what do you do about it? How do we get organized? How do we work on it? Typically, these things are about probably 11:30 or so, maybe noon, Colorado time, but I'm not sure yet when it'll be, but it tends to be mid-morning California, so it's an hour later here. And I'm really glad you brought that up because that was one of the most important action items I wanted to share with you.
Questions or comments? We have the room till 5, so we don't have to.
So I would like to, I'm Ailene McCarran, and I work with Colorado Ceasefire, and I liked what you said about good prevention is bipartisan, but working on gun violence prevention, it's a hugely polarized issue, and the laws we passed in 2013, there were no Republican votes for at all. And do you have any words of hope for us or ideas of where we can reach out to be bipartisan?
Well, a word of hope, because I got a tweet this morning from a friend who's actually a reporter in the state of Washington, is that the governor just signed a piece of legislation in Washington today on gun safety. In California, there was a referendum on the ballot for stricter, you probably know more about this stuff than I do, stricter safety related to guns and issues related to bullets. And what was unique about that, because it was a referendum, it was the people rather than the legislators who are affected by the National Rifle Association. I would say the number one word is local. I think we may see some small symbolic movement just because President Trump has, said that, he thinks there's problems with having a no-fly list and having people with guns on it. And, but I think the answers are going to be local. And it's harder here than in California. But it's hard in California, and we've succeeded by building momentum. And with people like you working on this, it ain't going to happen nationally in a big way. No hope.
Do you know what the legislation is that was passed in Washington State?
I don't know the details well enough to say it. Yeah. But Tony Gomez is the person who was speaking in the photo I got in front of the governor. He works I believe he's with the Seattle Health Department still, but he's the leader. He's someone I have tremendous respect for, and we can contact him for any information we need.
Hi, my name's Dennis. I work here at the School of Medicine. I'm a research assistant. So you kind of spoke a lot about, and we kind of asked a lot of questions that revolved around communication without actually talking about communication. So can you talk a little bit about like the importance of like getting this kind of information out to the public, where I think, you know, if the public really starts seeing the benefit, you know, it might spur more grassroots change.
I think that you just said it, and I think that's very smart. I think that our communication strategies must be not to talk to ourselves. And that's rare. And I think I will take that to the planning for this national meeting and ask that some of the communications people come together and really think about what are some of the more effective elements, some of the more effective messages. We've been just, as an organization, we've been just speaking up. There's so many things to speak up on. And the question is, which are the most important? What battles do we fight? You know, and in some ways we need to speak up for individual battles. You know, I'm actually, interestingly, I had an article published in the Houston paper today. As you know, the Super Bowl is Sunday, as many of you know. And so I had an article about the dangers of football and the problems with concussions. And the NFL didn't, they were offered the right for a companion article, but they chose not to write one. But speaking up is really, really important, and really defining a strategy much better than I'm able to do. But I think that's a great, rather than a question, I'm going to take that as a suggestion and say it's a great suggestion.
Hi, I'm Jan Updike. Can you comment about the future of community pull and professional push? If I can say, the public health sector being the push of prevention, while communities have their own priorities or may have activists that have some strange idea about some need.
I mean, I would say there always has to be a balance. I think that public health often gets lost in talking to itself or not being community responsive enough, and that we really need the wisdom of the community. I would say also, I've been in situations where people say, oh, we're just going to listen to the community, we're going to do what the community wants, and we need to listen to the wisdom of practitioners. I mean, I'm doing the work I'm doing right now because I've spent years trying to figure out what's effective in this work, and I want to make sure that when people do work, they do work that's effective, because these are very, very serious issues. We're talking about health, and nothing matters more than health. And we know how to prevent things, and we need to do that. So I want to stay away from the strange messages, but at the same time, I want to say that community really, really matters. And furthermore, a lot of political issues sustain if there's ongoing community push. I've seen things where it's behind, like some of our violence prevention work. The mayor adopts it or adapts it. The next mayor comes along, wants something new or different, even if they're just going to rename something, the same thing with a new name. That doesn't happen when there's strong community engagement. That doesn't happen when there's strong community effort, which I think goes back to your comment as well.
I'm Lauren Ambrosic. I work for an organization called the Colorado Prevention Alliance, which is an alliance of public and private health insurers and our community partners. And when that group got together, it drew a lot from the National Prevention Strategy and that whole alliance that came together. And we don't hear as much about them anymore. And because you mentioned that group, I'm wondering how that will be affected and how we'll be able to continue to draw from the work that that group is doing. I would strongly suspect that the National Prevention Strategy will be eliminated. It's probably seen as partisan. It's clearly associated as an ACA innovation.
there were two parts to it. There was an advisory group, and there was a consortium headed by the Surgeon General of agencies. I think if we can get the right understanding and thinking within health, there'll be an understanding of how to get different sectors to collaborate. But another idea that strikes me around the advisory group is we don't necessarily need federal government support to set it up. And the fact that you got a group here, there's a tremendous, it's a slightly different perspective, but Health and All Policies group in California. It would really be interesting to say we need that wisdom on a national basis, and it's probably better that it doesn't sit with government. So I think that's an interesting idea. The last meeting the National Prevention Strategy had, by the way, was on violence prevention and on gun violence prevention specifically, not on guns specifically, but on gun violence prevention specifically. And they made a commitment, and they wrote the letter to the next generation, which would have been now, urging that that be the entire emphasis of the National Prevention Strategy. So just another example of something that's not moving forward.
I was going to ask about climate change and if what are you hearing about movement in that area?
Nothing good. I think that it's terrible and devastating. I think that that's an issue we can't compromise on. One philanthropy that's fairly powerful has said they don't really want to use the word resilience anymore, even in relation to other health issues or equity issues, because resilience is also associated with climate change. And that's how pervasive the impact of stuff can be. So, I mean, on the climate level, on the level of clean rivers and, lack of environmental damage, and we haven't had this level of damage potential since the leadership of a woman named Ann Gorsuch, whose son is now nominated for the Supreme Court.
That connection.
So I wanted to say one thing, by the way, which I wanted to mention, because I wrote a book, which is called Prevention Diaries, and I have postcards about it too. But the goal of the book was to come out exactly after the election, and it's been extraordinarily disheartening for me because I really thought part of it could be part of the agenda of a new administration where we could really move prevention in a way it's never moved before. But I just want to encourage people to look at it, to read it. And there's ways to get whatever pieces you need without paying for it. But it's aimed more at the general public. It's aimed for people understanding that prevention matters, that prevention's about multiple people, multiple sectors, multiple issues, that there's a methodology and a strategy to it. It's not just about eating well. So I did want to mention that to people and encourage you to take at least the flyer if you're interested.
So I feel compelled to ask about research and prevention since I'm sitting at a research institution. So curious about what the rumor mill or fact mill is around HRQ and PCORI and all those sorts of things. Are you hearing anything, and what should we?
It sounds like she knows. Are you nodding because you think it's a good question or because you have the answers?
Yes, someone told me the PCORI grant, HRQ grant. The people work on biomedical informatics, very sensitive to those. At Charleston,
I had heard that there was bipartisan support for PCORI, but I have no idea at what level, certainly this sounds more accurate than what I'd heard, but I had heard there was bipartisan, and I hadn't heard anything about AHRQ. Some of that, though, my sense is the medical industry is a very, very powerful industry, and that if things like AHRQ are really helping them, that they'll put some weight behind them. But I'm guessing.
Other comments or?
I wanted to pick up, you made the really good point about this complex circumstance of talking about equity now post-election and, post-hillbilly elegy and this sort of thing. Do you have any thoughts about that sort of reframing and what that looks like, and not ignoring the original messages, but trying to figure out how that becomes more inclusive, less politically correct, that all the stuff that has made that such a fraught topic?
The framing I've always used, and I think may work for this, is that rather than kind of either or, has always been that everybody's facing, or almost everyone except the incredibly wealthy, successful, whatever, privileged, everybody's facing some of the same issues. And that different barriers produced by inequity mean the same struggles, only more so. And I've really tried to go with this more so. When I was in Kentucky, someone asked a question about equity to the health director. He said, well, the first thing we got to do, we have no people of color within the state health department. The first thing we got to do is hire more people, which I thought was a good statement, particularly if you knew who this guy was. But the second thing he said is, but that's going to take a real long time. But meanwhile, I just want to say that the people in the coal country in our state are in much worse shape than the African Americans in Louisville. And that's where we got to put our efforts first. He didn't even say that's where we got to put our efforts first. And this separation, I think, any way you do it is inappropriate and offensive. We've got to go with compassion for anyone who's being disadvantaged. And when there are things in the structure that create more disadvantage, that we can improve. And so then we have to speak in a slightly different language. I'm not sure that fully answers your question, but that's what I'm thinking of.
When I'm struggling to have these conversations, that I'm bumping up against a zero-sum mentality, and I don't think I do a very good job of emphasizing interdependence and how my existence is enhanced when somebody else is doing well. Is that worth going after things that way, or should I just abandon that? I don't. It's on me, my flaws in being able to do that. But I feel like that's such a pervasive way of thinking. If anybody gets something, I don't have it, and then it always seems like it's dead in the water. Then I don't know.
I mean, I think there's certain examples we can give that show that particularly extremism of, say, economics, damage almost everyone. I still think you're absolutely right that intuitively people are stuck in the zero-sum game, and it doesn't make a lot of sense. I think we're better off with the Trump stuff from the election, which is there's all these rich people who are ripping us off. We're going to drain the swamp. And continuing that theme and saying, wait a minute, I'm not sure it's happened yet. But we got to do something. We can't get, the whole reconceptualization of how healthcare is going to be managed, I think, is to move money to health service accounts, HSAs, health savings accounts. And that only makes sense if you pay a lot of income tax. So it's kind of saying, oh, you won't have health care, you'll have insurance, but you can buy insurance from all the money you're saving, but the only people saving money are the people who are saving a lot on taxes. So it's all fallacy-based. But I agree with your struggles. I think it's hard to be persuasive, but I do think that we'll see a lot more writing about this very soon. Yeah.
Some of us in this room are of the generation that took to the streets around the Vietnam War, the Civil Rights Movement, the women's movement, but many people in this room didn't experience that time in our history. I wonder, what your thinking is for people of this generation, what the strategies are we should be using to take action.
I don't think we're going to have any choice. I think we're going to have to take action, and the question is how to do it with a unified voice. There's way too much at stake. Just the climate change question, and then there's the health, and then there's the economic plans for, that are designed to say people are going to save money, but actually are designed so that rich people get richer, and then the educational system, being given away. I'm not sure what kind of taking to the streets works right away. I think we cannot create a situation where there's complete polarization. We need to create a situation where where people do not get defensive because of their votes, but instead there's a shared vision about a new sense of direction from at least some of those people. I think that this, in my lifetime, is by far the worst administration imaginable, and I have fears that it could be far worse than that. And that's not a particularly bipartisan thing to say. I think there were a lot of people with good reason and well-meaning who voted for this administration. And I think a lot of people don't understand what government is and does and why it's not just something, we'll see. I was saying, if we could have had like a TV program that portrayed this for a few months on TV before the election so that people understood the implications. I didn't think that could happen. I think that the first thing that's going to happen is there's going to be fragmentation between Democrats and Republicans. The next thing and Republicans will all come together. And the next thing that will happen is there's going to be internal fragmentation. As a friend of mine said, it's not just Trump who has a huge ego, all these politicians have huge egos. And there's a real battle right now between decision-making by Congress and decision-making by the administration. And that won't necessarily always be a comfortable battle. But I don't know. I haven't figured out what the strategy is. On prevention, I'm real clear. The strategy is this is a bipartisan issue. We're going to speak to everyone. We're going to emphasize to everyone that health matters. I think on climate, there's some of the same stuff. I just want to say, I'm not closing this though, unless it's the end, but I just want to say that I've really, this is very challenging, and I feel very inadequate, and I feel very appreciative of this conversation and appreciative of, everybody thinking, engaging, trying to do something. And we'll succeed. It's going to be a very hard struggle, but we'll succeed.
It's more of a comment. I heard this yesterday, and it was saying that one of the things we need to do is quit being siloed on our issues, that those of us concerned about gun violence should be out there working on racial justice and the others, but there becomes a little, and also climate change and environment and all that, and that we get more unified. But the thing is, we're getting assaulted on everything, and how much can we, there was a tremendous amount of energy in the Women's March a week ago or so, but how much can we, 2 weeks ago, but sustain that and continue? People have their lives when it's just everything is in ourselves. I don't know quite what I'm...
No, I think there's a couple of things I want to say about that, because it brings me back to Carol's question. I think what's also important about Vietnam and the demonstrations is that we succeeded. We changed the government. We changed the policies. We changed the war. We saved lives. And unfortunately, because energy is limited, we're going to have to sustain more than we feel able to sustain. There's a lot of fighting here. And I think it's a mix. I think there's some times and in some ways we really need to come together. And I think that the Women's March already had an incredible impact because it gave people who were concerned a sense of hope and possibility, and it gave people who were being extremely audacious and mean a sense that they can't get away with as much as they thought they can, and that there's going to be a big response. So that was already a big success. And I think just by saying it's a big success is a reminder we need to do more of it. And I think we need to do more of it. And also, your work on guns is needed. So you got to do both in a way. But you can't do every bit. I mean, I didn't go to the march. You know, it was right near my office, and I didn't go to the march because I said, I'm preserving my energy for something else. I'm trying to do this prevention stuff right now. You know, I was thrilled with all the marchers. Our board, between our board and our staff, we were in 8 different marches around the country and around the world. But, you know, so it is balancing, you know. We really have to take care of ourselves. We have to take care of ourselves through this, and we got to have some fun. You know, we got to realize that this is crappy, but it's an opportunity. We're privileged to have the opportunity to fight back.
I said that was the last one, but let's see that. Okay, that's okay. Not out of time yet. Okay.
Hi, my name is Shannon Fitzpatrick, and I'm with the Violence and Injury Prevention Mental Health Promotion branch of CDPHE.
Also known as the State Health Department, for those who don't.
Thank you. Yeah, it's a whole mouthful. I was just curious, my position and my team's position is that we've recently started coaching and guiding local communities to install communities that care into their communities. And if you could share one thing with me, you started your conversation, this conversation, with basically saying something to the effect of that we just have to move on. Like, we have to keep going forward. If you could share one thing with me that I could share with my communities that could keep them going forward in this time. That makes sense?
Well, I think in terms of what you're describing, we know that a lot of decisions and a lot of actions and a lot of success is local. And despite what's happening in Washington, if that's why people are feeling not hopeful, there's a lot that you can do in your local community that really, really matters. I mean, I came from a local community where nobody had any food, and this new group organized was mostly African American, and they said, we're going to feed the kids in our community. There was no support for that, no interest in that. They were called the Black Panthers because they were called the Black Panthers, and they weren't going to get credit for feeding the kids in the community. It's in the book, by the way. I have a copy. For you. Because the Black Panthers weren't going to get credit for it, we got a national school breakfast program, which in that very community, the churches were organized so that they could be funded, so that the Black Panthers didn't even have to get funded in Oakland. But a lot of really, really good work goes on in local communities. The difference, you know, sometimes I think now about Nazi times, the level of clarity that what's happening here is not okay, the level of rebellion, the level of dissent, the level of common sense, we've got a lot to build on. It's going to be crappy, it's going to be lousy, it's going to be hard, it's going to be exhausting, but we've got a lot to build on.
With that hopeful note, we should close the session.
Keep in mind, I'm sorry to cut you off, Carol.
That's okay.
Keep in mind, this is remarkable. Yeah. I mean, I actually thought I'd be talking to 5 or 6 people sitting around a table. This is absolutely remarkable. And this is a sign of strength commitment, compassion, wisdom.
Yeah, and I'd like to thank Larry for agreeing on very short notice to do this session with us, and also to thank all of you for coming and encourage you, as Ailene Corrado did at the beginning, to come to others in a series similar to this as we continue to talk about these issues. And also, I've been reading Larry's book, and I think it is a very
And helped
hopeful,
me to get it right.
Huh?
And helped me to get it right.
And it's a very hopeful book full of stories that you can use in your communication strategies and just keep the fire alive. So I would encourage you to get the postcard that he has and to look for the book. And maybe he'll even autograph it for you sometime.
Hi.
Julie Myers. The reason I smiled when you mentioned Pittsburgh, California is that my daughter-in-law teaches high school physics.
Oh, you're kidding.